Thank you, Dr. Neeta Deshpande and Dr. Sanjay for inviting me. This is relatively uncommon topic. Clinical trials in lipidology that have impacted the clinical practice before 2017 and after 2017. So what I'm going to do within next 20 minutes, I was told 20 minutes.
Yes.
This is saying
The timer will have to rectify. Please continue.
So, what happened before 2017, number of trials were there, lessons from statin trials, potential time course of statin effect in coronary artery disease and ACS, there are number of trials. Lower is the better with LDL, that is the statin decade. Pleiotropic effects of statin that we have learned over a period of time before 2017, and there were many controversies with statin. I'll just dwell upon them. After 2017, as Dr. Ajay Kumar told you, PCSK9, there are number of trials with that. Icosapent ethyl, another very important molecule, very important trial, reduce it. And then integrating the clinical data into clinical practice, what is the evolving treatment algorithm for lipid management. 20th century is the century of cholesterol and coronaries. The path by which cholesterol became linked to coronary heart disease is one of the great biomedical stories of 20th century. First of this century was era of cholesterol, followed by era of LDL. You can see how the things progressed to 2006 when we had PCSK9. Statins are taken as panacea. I'll tell you why. What are the lessons that we learned from various statin trials? Number of them are there. If I just keep on counting, it will take more than 20 minutes. Just naming them. You can see that 4S, lipid, HPS, 4S, SKR, TNT, A to Z. Number of them are there. Then ACS patient on statin therapy, follow-up for 5 years. The first one was prove it, MI or unstable angina, and the relative risk reduction was 16%. P is very, very significant. Then ideal, the longest follow-up is 5 years. Relative risk reduction of 18%. That is all MI patients were taken. If you look at the time course of statin effect in CAD and ACS, there are a number of trials that we have learned that lowering LDL, what it does, initially, over a period of hours or days, inflammation is reduced. Inflammation is reduced. That is why in ICU or CCU, we use high-dose statin to reduce inflammation, followed by endothelial function, which is restored. The vulnerable plaque is stabilized. The ischemic stroke episodes are reduced. And ultimately, over a period of weeks to months, cardiac events are reduced. Number of trials, I'm not going to name them, just what we have learned out of them. Pleiotropic benefits, everybody knows it is not only LDL, that is only the marker of efficacy of statin. Number of things happening with statin, and you get ultimately reduction in various cardiovascular events. Then looking at the level of LDL in various trials, the decade of statin said the lower is the better. Dr. Ajay Kumar, who said that he is Stephanie for international speaker, that Stephanie is as good as the original one. He told you that there are number of trials, and look at this, prove it up to 70. That is why the guidelines till 2017 said that you reduce LDL to 70 in a high-risk patient. But beyond that, there are data of further reduction of LDL in getting good results. I'll dwell upon that. Trials with drugs beyond statin. That has become increasingly important during last 4-5 years. Improve it, the first one, 2014 or 15. Look at the design of the trial. More than 10,000 patients, stabilized post-acute coronary syndrome, less than 10 days, LDL of less than 125 or less than 100 if on prior statin. They were divided into either standard of medical care, with aspirin and standard of medical care, one arm having statin, 40 milligram, other arm having ezetimibe plus statin. And look at the data. There is very significant reduction in various lipid parameters. Beyond that, there is reduction in hsCRP. Remember, this ezetimibe was thrown out few years back. It made an entry with a bang. Look at the data. On the top of simvastatin, the Improve It trial showed that cardiovascular death, MI, documented unstable angina requiring rehospitalization, coronary revascularization, more than 30 days, and stroke. So this was a 5-point MACE, which showed a very significant reduction. Number needed to treat is 50. CV death, non-fatal MI, non-fatal stroke, 3-point MACE, Improve It, that is simvastatin plus ezetimibe, there is a reduction of these events, and number needed to treat is 56. So what Improve It told us, this is the first trial which demonstrated that clinic incremental benefit when you add a drug which is a non-statin agent to statin therapy. Non-statin lowering of LDL with ezetimibe reduced CV events. Dr. Ajay Kumar told you that niacin failed. Lower is even better. What they achieved was 53 milligram of LDL versus 70 milligram at 1 year. So 53 is achievable, is safe, and reduces CV events. It confirmed that ezetimibe is safe, and further confirmed that LDL hypothesis that reducing LDL-C prevents cardiovascular events. So 2015 NEGM editorial said, proof that lower is better, LDL cholesterol, and Improve It. Now coming to controversies with statin. This statement is a big one. There are many who joke that statin should be added to drinking water. And with exponential growing number of those who are prescribed statin, they might as well. And this was one of the editorials in a very reputed journal. What do editorials say? This is Lancet. New US guidelines spark controversy. Cholesterol and controversies past, present, and futures, exploring the great cholesterol myth. Then another editorial said the cholesterol and calorie hypothesis are dead. It is time to focus on the real culprit, that is insulin resistance. Now, there is a controversy of new occurrence of diabetes or destabilizing the glucose homeostasis. This is the latest update, 2018 ESC, 1 case per 1,000 patient year of exposure with statin, but this statin prevents 5 new CV events. So that myth is also busted. Coming to after 2017, if you integrate recent clinical trials evolving treatment algorithm beyond statin, you can clearly see that the first half we already know. There are ample number of trials to show that statins are very good drugs. They are effective in lowering various events, but something beyond that, that is step 3. You can add ezetimibe, like Pruvate, or you can add other lipid-lowering therapy that includes PCSK9 inhibitors. Now coming to clinical trials with the drugs in combination with statin, PCSK9, there are a number of them, FOURIER, Odyssey, SPIRE 1 and 2. SPIRE was stopped prematurely because of very good positive results. Niacin, Dr. Ajay Kumar told you, AIM high was negative, HPS 2 thrive was negative. Very recently, Reduce It was a positive trial with icosapent ethyl. Coming to PCSK9 inhibitor trials, the first one was evolocumab that was published in 2017, and it showed that evolocumab are effective in lowering LDL. You can clearly see the significant reduction. Up to 30 milligram of LDL it could achieve. There are many people who will think, 30 पे क्या जिंदगी रहेगी? But there are data to show. Look at this, the CV outcomes, relative risk reduction. CV death, MI and stroke, the relative risk reduction is 16% with evolocumab. Relative risk reduction again is 25%. So, and P is very, very, very significant. This is what happened with evolocumab in FOURIER trial. Coming to another Odyssey trial, alirocumab. There is significant reduction of LDL between around 40. Intention to treat, add-on treatment. This was on the top of statin, adequate statin therapy. Another one, bocosumab, SPIRE 1 and 2. Look at the study design. Very high-risk patients on statin for 4 weeks, and data are really astonishing. There are ongoing trials with inclisiran. There are many Orion trials which are already published. This is Orion 8, which is still going on. Another ongoing trial is Valselius. This is again with evolocumab. So, if you re-evaluate LDL cholesterol targets, reduction of LDL further beyond 70 causes reduction of CV events. There is increasingly good benefit of further reduction of LDL. Lower the LDL achieved, greater is the reduction of CV risk. Clinicians should re-evaluate LDL-C targets for patients with known atherosclerotic cardiovascular disease, or if you find a patient who has got high risk factors. Reduce LDL-C levels to less than 40 milligram per deciliter, where they show that there is benefit. So 2017 onwards guidelines, non-statin recommendations. ACE was the first one, American Association of Clinical Endocrinologists, in April 2017. They acknowledged that adding non-statin therapy improves CV outcomes. Then May 2017, update on use of PCSK inhibitors in adults. This was from National Lipid Association expert panel. October 2017, non-statin therapy in atherosclerotic cardiovascular disease. This is from ACC. January 2018, ADA also acknowledged, a bit late, but still, now they have acknowledged that reducing LDL beyond statin is useful. November 2018, American College of Cardiology and American Heart Association further updated their guidelines based on recent non-statin drug trials. So what ACE recommendations are right now? In high-risk patients, reduce LDL to less than 100. Very high risk, less than 70. Extremely high risk, less than 55. Again, this is Circulation 2018. Number of guidelines have endorsed it. number of associations have endorsed these guidelines, and they clearly say that PCSK9 inhibitors are to be considered add-on to ezetimibe to maximum dose of statin before adding PCSK9. Then the last one was reduce it trial, which Dr. Ajay Kumar told you, cardiovascular risk reduction with icosapent ethyl for hypertriglyceridemia. And these are the data. 25% relative risk reduction. This is on the top of statin therapy. They were targeting triglyceride, and number needed to treat is only 21. Significant reduction in key secondary composite endpoints. CV death, MI and stroke. 26% reduction. Number needed to treat is 28%. So lessons from recent statin trials, lower is the better, but इस रास्ते पे बहुत कम लोग चले हैं. This path is relatively less traveled. With that, thank you very much. If there are any questions, I'll be very happy to answer.